Welcome to Desert Prostate Specialists, the office of David Schreiber, MD. And now, here's Dr. Schreiber.
Welcome to Desert Prostate Specialists. Today I'm going to speak to you about the way I approach prostate cancer in general, and also the techniques we use for biopsy in this office as well as for treatment, which is mainly with the seed implant. You know, when people come to my office, the first thing they want to know is, do I have prostate cancer, or is it even worth doing a biopsy? Well, in those situations, we want to look at certain bits of data, put them into the algorithm or the equation to figure out what the next steps are going to be. So the first step is looking at your PSA. The PSA is a really good marker, and it's a good first step in looking at prostate cancer. After that, we look at the rectal examination and determine if that looks suspicious. If both those things are suspicious, then usually we point to getting additional testing. This could include a more accurate PSA test called a 4K blood test, which looks at different types of PSA. Or we may do a urine test called a SELECT-MDx urine test, which looks at messenger RNA in the urine, which is a genetic material excreted by prostate cancer cells. If those things are suspicious, then oftentimes I will then recommend an MRI scan of the prostate. The MRI scan is the best way we have of looking at the prostate gland because it looks at the interior of the prostate, it looks at the capsule of the prostate, it looks at the seminal vesicles, it looks at the lymph nodes, it also looks at the bony architecture in the general area. We use all that information together to determine if an actual biopsy is necessary. And if it is, I will recommend that for you. Now, going on to the biopsy technique that we use here is different than you may see in the general urologic community. In a typical urologist's office, they approach from the rectal area. I do nothing through the rectum in this office. I think the rectum is a structure that can predispose to infection and bleeding and pain, and we don't like any of those in this practice. So when I do a biopsy, we do not approach through the rectum. We approach through a little patch of skin that's called the perineum, which is located between the scrotum and the rectum. And that little patch of skin can be cleaned so we don't get infections. Blood vessels can be avoided. So when a urologist does a procedure through a transrectal technique, they are limited on how much prostate they can get to. When I do a prostate biopsy, I come from a different angle, so I can get all parts of the prostate, front, back, left, right, top, and bottom. Also, when a urologist does a biopsy, they typically will never visualize your urethra. Your urethra is the area of the prostate that the urine goes through to get out, and it's right through the middle of the prostate. So they don't see it. I do visualize it because when I do a biopsy, we do put you to sleep. And we do that in a surgery center, all as outpatient. It's a very quick procedure. It takes 35 to 40 minutes to do. You're asleep for about an hour when you do that. And when we do that, that makes it a painless procedure. So when I do a biopsy, for one thing, it's much safer. We don't have those risks of bleeding and infection that people get with the transrectal biopsies. It's painless because we do knock you out for the procedure. And it's much more comprehensive because we use a technique in this office for all of our procedures called MRI ultrasound fusion. Now, MRI ultrasound fusion means the merging of images. We merge the MRI images that you have already had with the real-time ultrasound images that we obtain either in my office or in the operating room when we're doing the procedure. Another thing that typical urologists don't do is pre-plan a biopsy. Pre-planning is very important. It allows me to do a virtual biopsy on you in the office. And at that time, it's usually done a week or two before the procedure. We put you on your back on one of our exam rooms in stirrups. We put an ultrasound transducer in your rectum. We take a few pictures of your prostate, and we upload them into my treatment planning system. And then that treatment planning system will also have your MRI scan within it already, and I'll merge those images. When we merge those images, we can reconstruct the prostate and the abnormalities within the prostate gland on the computer screen. That way we can visualize, and you can visualize because you can watch this, your exact prostate and the lesions. Also on that computer screen, I will place virtually the biopsy cores that we take. A biopsy core is a sample of tissue that's usually less than an inch long, and I may take anywhere from 25 to 35 biopsies when we do a procedure, whereas a urologist might take only 12 or 18 because typically you're awake or under local anesthetic, and they can't do many more than that because your body won't really take that very well. You have a lot of discomfort. So we do a pre-plan here in the office. So those are some of the differences between how we do a biopsy and a urologist does a biopsy. Now you may experience some blood in the urine or burning in the urine after the procedure for a few days. This is normal. In very rare cases, like in people that have very large prostates, they may have difficulty urination and may, even in the most extreme cases, be obstructed completely and would have to have a catheter placed after the procedure temporarily. I do put a catheter in your bladder during the procedure so I can visualize that urethra and avoid it. I also look in your bladder with a scope at the time of the procedure to make sure everything looks okay. So we do a lot of things to prevent any problems from happening. We also give you medication such as antibiotic to prevent infection in the off chance you could get one, which we've never had in this office. We give you pain medication in the off chance you may have some significant discomfort, which again we really don't see. Most people don't take more than an extra strength Tylenol for the discomfort, but we do give you a Tylenol with codeine just in case. And we give you something to keep your urine flowing better. A drug such as Flomax, which will relax the smooth muscle in your urethra so you get better emptying before, during, and after the procedure. At the 1-week checkup, we're going to make sure that your little needle holes have filled up okay in that perineal area I described previously. Although you may get a little bit of bruising, that may last for a few weeks before it goes away. But the healing is usually quite complete, because don't forget, we don't cut you with a scalpel, we don't leave stitches behind. And then we're going to go over the pathology report. Now, the pathology report is either going to show cancer or it's not going to show cancer. If it doesn't show cancer, that's a really good thing, but we're going to send those specimens out to a second laboratory to do genetic testing. We do about 3 genetic tests on each specimen, and we know precisely from where I take each specimen, so it's well documented. And it will give me a report, and that usually takes 1 or 2 weeks to get that report back. And if that report says negative, also like the original biopsy, then I'm going to give you a 95% confidence that you're never going to have a significant prostate cancer for the rest of your life, which means no additional biopsies just because your PSA is a little bit above normal. You know, some prostates make a lot of PSA, just normal for that. We make more PSA as we get older. Prostate glands grow as we get older, so that's all normal. And we don't recommend anything after that situation except for maybe 1-year follow-ups with like any other guy with a rectal exam and a PSA blood test. If the genetic testing comes back positive, on the other hand, then we're going to probably recommend a second biopsy for you just to that location in the prostate, because I'll know precisely where it was. Instead of doing 25 or 30 biopsies, as I already mentioned, we may just do 8 or 10 biopsies just to that one spot. There are no third biopsies. If the second biopsy shows cancer, of course, we'll do something about it. But if the second biopsy shows no cancer, again, you're still in that same 95% category of never having a significant risk of prostate cancer. So we get a very comprehensive evaluation of you with this biopsy. I usually tell patients this is the only biopsy you'll ever need. We're either going to find the cancer that other people can't find, or we're going to give you that great confidence that you're never going to have a significant prostate cancer. If it's determined by the biopsy you have prostate cancer, we have to determine what risk category you fall into. Risk categories are determined by a combination of looking at the pathology report and looking at the PSA value that you had initially. Now, the pathology report is reported in something called a Gleason score. A Gleason score is the addition of 2 grades that we see under the microscope. So the grades range from 1 through 5. 5 is the most aggressive, 1 is the least aggressive. So we add the 2 numbers up that we see and we get a score. And the Gleason score can be anywhere from 2 through 10. So we take those Gleason scores and add it to the PSA value and combine them to get a risk category. Now, the risk categories for prostate cancer are generally agreed upon to be very low risk, intermediate risk, or high risk. Low risk, or very low risk, I should say, is defined as a Gleason score of 6 or lower and only in 1 or 2 biopsies and a PSA less than 10. The low-risk patients, I certainly do like to treat. Low-risk patients are defined as a Gleason score 6 or less and a PSA of 10 or less. But it's usually more than 1 or 2 little biopsies positive. And certainly we can treat that. The next category is the intermediate risk category. That's defined as a Gleason score of 7 and a PSA less than 20, or a Gleason score of 6 and a PSA between 10 and 20. Those patients are always treated. And then there's high-risk patients, which are Gleason's 8, 9, or 10, or a PSA of 20 or higher. So how do I approach treating these patients? Well, all patients in this office can be treated with seed implant, either alone or combination with hormonal management. If we treat with seed implant alone, I'm going to describe that procedure to you. If we add hormone treatment to the treatment, we usually give hormones in the form of a shot, which actually prevents you from making the male hormone testosterone. It's called Eligard or Lupron. The way they work is they start in your brain and they prevent the brain from making one hormone that makes another hormone that tells your testicles to make testosterone. So it's a very powerful shot, and this makes your PSA go way down, sometimes even to zero. It makes your testosterone go to zero, and it puts you in remission right away. It will decrease the size of your prostate by about 30 to 50%. So it's a good adjunct therapy. It's been shown to improve survival in the high-risk patients when we use hormonal management, sometimes for as little as 6 months to sometimes as much as 2 years. It's not an easy treatment for some men because it does have side effects. You can lose your sex drive, you can get hot flashes, which we can treat, much less likely diarrhea, bloating, weight gain, or fatigue. And these side effects take about a month to notice once you get the shot. The shots I give in this office usually last about 4 months. And shots come in various strengths. They can come in 1 month, 3 month, 4 month, 6 month, or even 1 year shots. I've settled on the 4 month shot because that's long enough to get an effect, but not so long that if you're suffering from side effects that it will take a long time to go away. So I usually don't recommend those shots unless people have very large prostates that need to be decreased in size, even in very low risk patients, or in patients of high risk disease that we need to use as what we call adjuvant therapy for anywhere, like I said earlier, from 6 months to 2 years. Another form of therapy for prostate cancer that is sometimes used along with the seeds is external beam radiation. I do not do external beam radiation in this office anymore, although I have extensive experience with it. External beam radiation is radiation that bombards the cancer from the outside of your body to the inside of your body. It's usually given in daily treatments, Monday through Friday, 5 days a week, and it goes on for several weeks, anywhere from 5 to 9 weeks. The purpose of that is to treat not just the prostate, but the areas around the prostate if they're considered at risk. We find much less use for external beam radiation these days, especially through this office, because we have other tests now that help us determine if there's disease outside the prostate that we never had before when all this data was originally gathered. Now we have a test called the PSMA PET-CT. I use that in high-risk patients. That's to determine if we can see any cancer outside the prostate. Even though we have an MRI that may not show cancer, this PSMA test is more sensitive at finding small bits of cancer that could be possibly in the lymph nodes or in the bones, anywhere else in the body. So if you're a high-risk patient, I typically get that test. If that test is negative, then I'm pretty confident I can treat you with seeds only without the need to add external beam radiation. And even the question of hormones is evolving now. It used to be that hormones were either given for 6 months along with external beam radiation and seeds, or hormones were given for 2 years with just seeds. And that's even more recent. But now there's more testing. Even the Polaris test I mentioned earlier can determine how aggressive that high-risk cancer is to determine if you actually need hormonal management at all. And it would be a great thing for men if they didn't need hormonal management, because men really love testosterone. They love it more than women love estrogen. We don't like having our testosterone removed. So anything I can do to prevent you from being on hormones, I'm going to do. Now, hormone manipulation can be also given in the form of a pill. We call Casodex is the one we use in this office. That's a much gentler hormonal manipulation. I use it in cases where the gland is just a little bit big, or we're trying to delay therapy for a little bit. It will put you in remission as well, but it won't be as powerful. The side effects aren't as severe. It does not prevent you from making testosterone like the shot does. It prevents the testosterone that you normally make from working. Now, that means you have testosterone floating around in your system, but this pill actually prevents the testosterone from binding to the receptors in the cancer cells and stimulating their growth. So it does put people in remission, and you get about a 20% reduction in the size of the prostate. So sometimes I recommend that in various situations. And what about the seed implant itself? That's what we do here in this office. The techniques I use for seed implant are similar to the techniques I described to you for the biopsy. We do a pre-plan, just like we did for the biopsy, and we do MRI and ultrasound fusion in all cases. You know, in the operating room, we have a large screen TV where I reconstructed the prostate gland, all the lesions within it, and we can watch our needles go exactly where they need to go within those lesions, and also to treat the entire prostate if we're doing that type of seed implant. Some seed implants I do are called focal seed implants. That's really for the very low-risk patients or people that have low-grade disease just on one side of the prostate. But typically, we're treating the whole prostate gland. But a seed implant, I can place seeds in the prostate and conform the dose, not just to the prostate gland itself like other treatments, but within the prostate gland. So if you have lesions that are localized more to one side than the other, I can actually give more radiation to one side or the other. When I do a seed implant or even a biopsy, we use what's called template guidance. This is an example of a template. It's got letters and numbers on it. And this correlates to a grid that we see in our ultrasound machine and also on our computer screen in the pre-plan. Don't forget, in the pre-plan, whether it's a seed implant pre-plan or a biopsy pre-plan, I've done already a virtual seed implant on you or a virtual biopsy on you on the computer screen. So in the operating room, we're just emulating that, but we're actually using this template up against your skin in the perineum, as I described earlier, between the scrotum and the rectum. Then in a biopsy procedure, we're using a biopsy gun, which is a needle like this with a trigger on it to take the biopsies, but with a seed implant, we're using a needle like this that has seeds preloaded within the needle, and I can put the needle into the skin, up into the perineum, and then up into your prostate gland, which I can watch on this big screen TV and on the ultrasound machine for image guidance during the procedure. And then I can drop the seeds through these needles, and then I remove the needle like that. So the template helps us very precisely place things. It's not a freehand technique like other people use. In the operating room, of course, we're putting in seeds now. And before I put in seeds, I use something called Barrigel. Barrigel is a gelatinous material that's made out of hyaluronic acid, which is a naturally produced body substance. We all have it. It's filler. If you go to the plastic surgeon, you don't like that wrinkle, they put that filler in there. What that has the effect of doing is increasing the distance that the radiation has to travel to get to the rectum from the seed implant. This preserves rectal function, decreases rectal complications dramatically. It's painless for you. So we put that Barrigel in at the very beginning of the procedure. Then we place the seeds during the time of the procedure, of course. Use the scope to look inside your bladder and your urethra to make sure everything looks okay and there were no seeds left behind, which almost never ever happens. And of course, we put the catheter in your bladder to visualize your urethra so we don't accidentally put seeds in there. At the same time that we do that, we're looking for any other problems that could possibly be in the bladder, urethra. We remove the catheter before you wake up. So you do not wake up with a catheter in after a seed implant in this office. Again, after you recover, you go home. Same short-term side effects as the biopsy that I described earlier. And then the 1-week checkup now, we're just checking your skin to make sure everything's healed up okay. Obviously, there's no pathology report to go over, but we do send you for a CAT scan after the procedure. That CAT scan is done to document where all the seeds are within your prostate for our quality assessment in our post-implant planning period. By the way, we do a CAT scan before the seed implant if you haven't already had one to look at your bony architecture to help me determine the angulation of the needles I'm going to use through that template in relation to your bony architecture of your pelvis, your pubic arch, and things like that. After that, follow-up is quite simple. We see you back about 7 weeks later for your first PSA blood test and rectal examination, and then you're seen every 3 months for 2 years, then every 6 months till 5 years, then just once per year. With each and every follow-up, we do a rectal exam and PSA blood test. That's all the testing that you need. If the PSA is low, it means you don't have prostate cancer anywhere in your body that's active. And the rectal examination is a confirmation. Sometimes you can have an abnormal rectal exam with a normal PSA, and sometimes you can have an abnormal PSA with a normal rectal exam. So they are complementary to each other. Oftentimes I see people coming to me in consultation, they've never had a rectal exam, even though they're sent to me for possibility of prostate cancer. I don't quite understand that because that's part of the evaluation for this disease. Long-term complications from a seed implant are very rare. It's less than a 1% chance of any injury to the bladder or the rectum. Semen production can be decreased after a seed implant, and it may be permanent, although I've had some men tell me that the semen does come back after a while. And that's because the prostate gland is a secretory organ, and it can make fluid, and when that secretory capacity is decreased, whether you're treated with any kind of treatment for prostate cancer, that production can go down. Other long-term risks do not include incontinence. We've never seen a case of incontinence with seed implant alone. That's leaking urine. And impotency is a risk. Now, impotency is about a 20% risk with a seed implant, but fortunately about 80% of men have that impotency relieved by medications such as Viagra, Cialis, and Levitra, things like that. That's the lowest risk of impotency of any kind of treatment for prostate cancer. External beam has twice the risk. Surgery has 3 times the risk of impotency. Surgery has 10 times the risk of making you incontinent. So a seed implant has the lowest risk of any form of management for prostate cancer, both in short term and long run. Because the seed implant is an operator-dependent procedure, you want to go to a physician that does a lot of seed implants or has extensive experience doing seed implants. Fortunately, I do. I've done many, many thousands of these procedures, so I'm comfortable seeing people in various different clinical situations and handling unusual situations as they should arise. Now, what else is different about a seed implant compared to a biopsy? Well, most importantly, after a seed implant, you're radioactive, right? I put radioactive material inside you. We use various kinds of seeds in this practice, and we've used many in the past, but what I've settled on is iodine-125 seeds. Iodine-125 seeds have a half-life of about 60 days, and they take about a year to become virtually non-radioactive in your system. Now, the cancer can shrink up to 4 to 5 years to stabilize that PSA, but you're radioactive as far as a detector is concerned, for up to a year. But radiation precautions are necessary for only about 6 weeks, because at 6 weeks, you can barely pick up the radiation on your skin. So, what are these precautions? No small kids on the lap, no sexual activity, no spooning, no prolonged skin-to-skin contact on the front of your body and of the pelvic region. It's not very radioactive down there. Someone would have to sit there for about 100 hours to get a chest X-ray dose equivalent, but still we want to be extra sensitive. Now, everything else is fine from day one. You can sleep with whomever you want, you may travel, you may have pets on your lap, you can pick up a little kid and give them a kiss, you can be around pregnant women. All those things are all fine to do because the radiation is so weak. After 6 weeks, you don't have to have that at all. After the seed implant, we do give you a card for your wallet to keep, or you can take a picture of it on your phone to keep it. It just states that you're radioactive and why you're radioactive. This is very useful because there are sensitive radiation detectors located at some airports and some border crossings. And if they do pick up your radiation, you can just show them the card and they'll just pass you on through. I call that a get out of jail free card. If you forget the card, you'll still get through, but it might take you about 3 hours to get there and a lot of explaining to do. So I suggest that you keep it. So I love doing the seed implant procedure because I have experience with many other procedures for treating prostate cancer. These include external beam radiation, which I described a little bit earlier. External beam radiation has various forms, including CyberKnife, which is a radiation linear accelerator that's actually on a C-arm that rotates around your body. It gives a big dose of radiation over just 5 treatments. I don't like that treatment, and I don't like proton beam treatment, which is also another form of external beam radiation, which uses particle beams to treat the cancer. Both of those treatments give a very intense dose of radiation to a small area, but unfortunately, the area around there is very sensitive. And so in the short run, you don't notice much in the way of side effects because they have really good local control. But at 4 or 5 years out, I've seen complications from both of those types of treatments, including holes between the bladder and the rectum, perirectal abscesses. So we don't get those types of complications with a seed implant. Again, that's why it's an operator-dependent procedure. I believe the seed implant has the highest cure rate of any treatment, including surgery. It has the lowest risk. It has the least likely chance of affecting your lifestyle. It's the least expensive treatment by about 2/3. So when you do a seed implant, you feel good afterwards. In fact, we give you a picture of the seed implant to keep afterwards to prove that you actually had one. I have had patients in the past that tell me they didn't think I did anything to them because they felt so good afterwards. In this practice, the main goal is maintaining your quality of life. I look at everybody through that lens. Cure is a secondary goal in this practice because we cure almost everybody that walks through the door. So when you come in here, I look at your life. We want to work around your lifestyle. I want to leave you like I found you, minus the cancer. I want you to pursue all of your normal activities that you've always pursued, whether it's sexual, whether it's traveling, whether it's work, whether it's athletics. Anything that you're used to doing and you're comfortable doing, we want you to continue to do. And we achieve that goal almost every single time. Thank you for watching this video, and we hope it helps you determine what your goals are in treatment and in cure and in quality of life, which again is our primary goal in this practice.